So we will discuss about the uh, hypothalamic pituitary axis. So what is this hypothalamic pituitary axis? So the pituitary hormone, here is the pituitary hormone, then this is the hypothalamic releasing or inhibitory factor. These are the target organ, then and this is the effect. So in the pituitary hormone, that is the growth hormone. Okay, then when there is a growth hormone, hypothalamic releasing or inhibitory factors are the uh, okay. So these are the stimulated by growth hormone releasing hormone. Okay, it is growth hormone is stimulated by the growth hormone releasing hormone GHRH and inhibited by the somatostatin, also called the growth hormone inhibiting hormone. Okay, GHRH will increase the stimulation the growth hormone, and growth hormone inhibiting hormone or somatostatin will inhibit this growth hormone secretion. Okay, so which are the target organs? So liver, bone, and muscles. Liver, bone, and the muscle. Okay, liver, bone, and muscle are the target organ. Okay, direct effect regulates growth and metabolic rate. Okay, effect. So effect will be regulate growth and metabolic rate. Okay, then adrenocorticotropic hormone ACTH. So ACTH is stimulated by the corticotropic releasing hormone CRH. Okay, the target organ will be the adrenal gland and stimulates the release of the cortisol. Okay, as we all know that the corticotropin releasing hormone will stimulate the release of the ACTH, and ACTH will increase the stimulation of the cortisol in the adrenal from the adrenal gland in the zona fasciculata. Okay, then zona fasciculata. Then follicle stimulating hormone FSH and luteinizing hormone LH. Okay, so these hormones stimulated by the gonadotropin releasing hormone GnRH in the will act on the gonads and stimulate the release of testosterone or estrogen and production of the enzymes. Will stimulate the release of the testosterone in the man and release the sperm, and in the female release the estrogen and stimulate the estrogen and release of the eggs. Okay, then thyroid stimulating hormone TSH. Okay, about this the follicular stimulating hormone and FSH in the male and in the male, and luteinizing hormone in the female. Okay, now thyroid stimulating hormone stimulated by the thyrotropin releasing hormone. Okay, TSH will be stimulated by the TRH, thyrotropin releasing hormone. Effect done on the thyroid gland and stimulates the release of thyroid hormone. Stimulates the release of the thyroid hormone T3 T4 in the from the thyroid gland. Okay, and then prolactin. Okay, prolactin is weakly stimulated by the thyrotropin releasing hormone, oxytocin, and the antidiuretic hormone. Sorry, prolactin is stimulated by the thyrotropin releasing hormone, then the oxytocin and the antidiuretic hormone, and inhibited by the dopamine, also called the prolactin inhibiting hormone PIH. Okay, dopamine and the prolactin inhibiting hormone. Okay, so dopamine will inhibit the prolactin, and another one was the somatostatin inhibit the release of the growth hormone. Okay, so here when prolactin, where prolactin, the target organ is the mammary gland. Okay, and will direct effect stimulates lactation. Okay, direct effect is the stimulate, it stimulates the lactation. Okay, to feed the baby. its effect of the prolactin on the mammary gland. Okay, then antidiuretic hormone ADH. Antidiuretic hormone ADH from the posterior pituitary, uh, and the target organ is the kidney. Direct effect regulates the water balance. Okay, from the posterior pituitary, it will stimulated antidiuretic hormone and direct effect on the kidney, and which regulate the water balance. Then oxytocin. Oxytocin from the posterior pituitary, female reproductive system, direct effect on the female reproductive system, direct effect stimulate the milk ejection in sucking and the uterine contraction in the childbirth. Okay, stimulate the milk ejection in the sucking and contraction, uterine contraction during the childbirth. Now, hypothyroidism. Uh, so, hypothyroidism is characterized by reduced circulating T3 and T4. Okay, hypothyroidism is the decreased T3 and T4. Causes are the primary hypothyroidism, then secondary hypothyroidism. Then we will see the clinical features, symptoms, and signs, okay, of the hypothyroidism, and then we will see the investigations, and lastly the management. Then we will see the myxedema, coma. Okay, so causes. So the primary hypothyroidism, the causes are autoimmune, atrophic, and Hashimoto's. Okay, autoimmune. Then iatrogenic. In that, thionides, radioactive iodine surgery and radiation. Then hypothyroid phase of thyroiditis. Hypothyroid phase of thyroiditis. Then drug. These are lithium, amiodarone, and interferon. Then iodine deficiency. Okay, these are the causes of for primary hypothyroidism. These are autoimmune, atrophic or Hashimoto's, then iatrogenic, in that thyronamide, radioactive iodine surgery or radiation. Then the hypothyroid phase of the thyroiditis, and drugs like lithium, amiodarone, and interferon. Then iodine deficiency, hypothyroidism. Then the secondary hypothyroidism is due to TSH deficiency, secondary to the hypothalamic pituitary disease. Hypothalamic pituitary disease cause the TSH deficiency, and the hypothyroidism occur. That's called the second hypothyroidism. Then which are the clinical features? So in the clinical features, the symptoms are weight gain, cold intolerance, fatigue, constipation, depression, muscle cramps, carpal tunnel syndrome. Then menstrual disturbance and the reduced fertility. Okay, so in the hypothyroidism, the symptoms are the weight gain, cold intolerance, fatigue, constipation, depression, muscle cramps, then carpal tunnel syndrome, menstrual disturbances, and reduced fertility. Then which are the signs of hypothyroidism? So these are the alopecia, bradycardia, then dry skin, brittle nail, periorbital myxedema, goiter, and pretibial myxedema. Pretibial myxedema. Okay, signs are the alopecia, then bradycardia, then dry skin, brittle nail, then periorbital myxedema, peritibial myxedema, and the goiter. Okay, so which are the investigations? So T3, T4, and TSH. Low T4 with elevated TSH, primary hypothyroidism. Then normal T4 with elevated TSH is the subclinical hypothyroidism, and low T4 with non-elevated TSH is the secondary hypothyroidism. Okay, T3 T4 TSH we will do in that. Low T4 with elevated TSH is the primary hypothyroidism. Then normal T4 with elevated TSH is the subclinical hypothyroidism, and low T4 with non-elevated TSH. Low T4 with non uh, okay, elevated TSH are the secondary hypothyroidism. Then thyroid antibodies, these are the TPO antibodies. Management, in management, thyroxine replacement to normalize TFTs and resolve symptoms. Okay, thyroxine replacement to normalize TFTs and resolve symptoms. Thyroxine will be given. Then, what is the myxedema coma? What is the myxedema coma? So, myxedema coma is the rare medical emergency with high mortality, requiring treatment in high dependency setting characterized by myxedema coma is the emergency, medical emergency. Okay, so in that, hypotension, then pericardial effusion, then bradycardia, reduced consciousness, hypoventilation, hyponatremia, renal impairment, and the coagulopathy. Okay, hypertension, decreased blood pressure, then the pericardial effusion. Okay, then bradycardia, hypertension, decreased pp, decreased pulse rate, pericardial effusion, then the reduced consciousness, hypoventilation. Decreased consciousness, hyponatremia, renal impairment, and the coagulopathy. Okay, and these are the signs of the myxedema coma, so we have to treat it immediately. Okay, then what is the insulin physiology? So what is insulin physiology? We will see the insulin physiology. In insulin is produced by beta cells located centrally within the isolate of Langerhans. Okay, insulin is produced by the beta cells located in the centrally. Okay, as we have seen earlier, there the isolate of Langerhans, in that this as if this is the pancreas, then this is the isolate of Langerhans, and in this the outside it is the alpha cell, and in the medially it is the beta cells. Okay, and this insulin is secreted by the beta cells in the endocrine tissue of the pancreas. Okay, then insulin is polypeptide hormone consisting of two short chain alpha and beta linked by this disulfide bond. Okay, insulin is polypeptide hormone resulting consisting of two short chain consist of two short chain alpha and beta linked by disulfide bond. Okay, insulin is the polypeptide hormone consisting of two short chain alpha and beta linked by the disulfide bond. Then the proinsulin is synthesized as a single chain proinsulin. Okay, as we have seen, this is the insulin structure, then this is the proinsulin. Okay, so proinsulin is the single chain peptide. Okay, within storage granules, the connecting peptide C peptide is removed by protease to yield insulin. Okay, within storage granules, connecting peptide C peptide In the storage granules, C-peptide is removed by protease to yield insulin. The C-peptide is packaged and secreted along with the insulin, and its concentration is used to monitor beta cell activity in diabetic patient who receive exogenous insulin. Okay, so the C-peptide, what C-peptide do, that it will its concentration is used to monitor the beta cell activity in the diabetic patient who receive the exogenous insulin. Monitor the beta cell activity who receive the exogenous insulin in the diabetic patient. Okay, insulin release is stimulated initially during eating. Insulin release is stimulated initially during the eating by parasympathetic nervous system and gut hormones such as secretin. But most output is driven by the rise in plasma glucose concentration that occurs after the meal. Okay, release is stimulated during the eating by the parasympathetic nervous system and gut hormones such as secretin. Okay, but the most output driven by the rise in plasma glucose concentration that occurs after the meal. Circulating fatty acid, ketone bodies, and the amino acid augment the effect of the glucose. Okay, fatty acid, ketone bodies, and the amino acid also augment the effect of the glucose. Major action of insulin is to stimulate glucose uptake. Stimulate glucose uptake. To use the glucose, it is stimulated by the insulin. Okay, so what do the insulin? The insulin will stimulate the glucose uptake with the subsequent manufacture of glycogen and triglyceride by adipose, with subsequent manufacture of the glycogen and triglyceride by the adipose, muscle, and liver cells. Manufacture of the glycogen, triglyceride by the adipose, muscles, and the liver cell. The effect of the insulin are mediated by the receptor tyrosine kinase. The effect of the insulin effect is mediated by the receptor tyrosine kinase. Insulin effect is mediated by the tyrosine kinase. The enzyme activates an intracellular pathway that results in the translocation of glucose transporter GLUT4 and to a lesser extent GLUT1. The effect of insulin are mediated by the receptor tyrosine kinase. Okay, the enzyme activates an intracellular pathway. Enzyme activates the intracellular pathway that results in the translocation of glucose transporter GLUT4 and the GLUT1 to the plasma membrane to the affected cell to facilitate the entry of the glucose. Insulin thus decrease the plasma glucose. To facilitate the entry of the glucose, and insulin thus decrease the plasma glucose. Okay, so what do insulin stimulate the glucose uptake and subsequent manufacture of glycogen and triglyceride in the adipose muscles and the liver cell. Okay, so the insulin will is mediated by the receptor tyrosine kinase, and the insulin will do the translocation of the glucose transporter GLUT4 and GLUT1 to the plasma membrane, okay, of the affected cell to facilitate the entry of the glucose. Okay, so the glucose entry will be increased by the glucose transporter GLUT4 and the GLUT1 stimulation, okay, to the affected cell, and insulin thus decrease the plasma glucose. Insulin release is reduced as a blood glucose secretion concentration falls. Insulin release will reduce as the blood glucose concentration will decrease. Okay, and is further inhibited by catecholamine acting at beta cell alpha 2 adrenoceptor. Okay, and is further inhibited by the catecholamines acting at beta cell alpha 2 adrenoceptors, inhibited by the catecholamines. Okay, now we will see the comparison between the insulin and the glucagon. As we have seen earlier that uh, hormones factors that increase the secretion. So insulin secretion from the beta cell increased by the increased blood glucose, increased amino acid, and increased the fatty acid. Then when glucagon is there, secretin is there, and the acetylcholine are there, and glucagon from the alpha cells secretion is increased by when the decreased blood glucose, when the glucose is on the lower side, increased amino acid, high amino acid, then the cholecystokinin, catecholamine, and the acetylcholine. Okay, and factors that decrease the secretion, so decrease the blood glucose, somatostatin, and the catecholamine. Okay, and here is the increased blood glucose, insulin, and the somatostatin. Okay, somatostatin will increase both and the acetylcholine decrease both the insulin and the glucagon, and acetylcholine will increase both the insulin and the glucagon. Okay, then mechanism of action. So, and the here is the fatty acid, sorry, fatty acid and the keto acid. Okay, now what is the mechanism of action? So acts on tyrosine kinase receptor. Insulin acts on the tyrosine kinase receptor to activate intracellular pathway that results in the translocation of the GLUT4 transporter to the plasma membrane. Okay, intracellular pathway that results in the translocation of the GLUT4 transporter to the plasma membrane. Okay, tyrosine kinase receptor will activate it. And in the glucagon act on G protein coupled receptor to stimulate the production of the CAMP. What is the major action of the insulin? So insulin will increase the glucose uptake into the cell, increase the glycogenesis, glycogenolysis, then decrease gluconeogenesis, increase protein synthesis, increase the protein degradation, decrease protein degradation, then increase fat deposition, decrease lipolysis, decrease keto acid production, and increase potassium uptake into the cell. Then glucagon will decrease the glycogenesis, increase glucogenolysis, increase gluconeogenesis, then decrease fatty acid synthesis, increase lipolysis, and increase keto acid production. Then overall effect on the blood level. So insulin will decrease glucose, decrease amino acid, decrease fatty acid, decrease keto acid, and decrease the potassium, and glucagon will increase all glucose, fatty acid, and the keto acid.